on in the process. This is called Project VIDA. VIDA translates in Spanish to life, and it's decentralization of HIV services in Peru. And the way that this got started is that I have a training research site in Peru, and I have another R01. And one of the things that happened was, when you get there, you meet with stakeholders, and this whole project grew out of sort of what did people find that was important. And so when we met with the Ministry of Health and the HIV services, we sort of said, what's not working well for you? And so it was all sort of organically, and we actually prioritized 4 different projects, and we've got one that's under review. I think we're about to be reviewed in the next week or 2 that has to do on scaling up PrEP. But the first thing that they said was, we've had a policy that we want to actually move all these patients from these large HIV clinics into these primary care centers. Since 2019, it was in their national guidelines. They had, sort of a whole statement on it. And they had a handful of patients. They had equipped all these primary care centers. They had designated, they make sure that they had the HIV testing, the pharmacy service, all this other sort of stuff. And, some of them had 10 patients and stuff like that. And, so one of the things that sort of, came into this is, you have to go back and take a look at, what's going on. It's an important issue for them, but is there anything new that we can sort of bring to the table with this? This is a paper that we published a couple of years ago. And one of the reasons why I come to sort of Eastern Europe and Central Asia is to take a look at where things are not going as well as you'd like. And so if you sort of take a look at what's happening in the world, HIV incidence globally has gone down, by almost 48% or so. So this is the last 10 years what's happened. And mortality has gone down a bucket load. But in this particular region, you see that Eastern Europe, the Middle East, and the MENA region, and Latin America, it's all going up still, all right? It's increasing, which means that they're not really putting together or doing the things that they want. And mortality has gone down, but overall 48%. But it's gone up in Eastern Europe and Central Asia. And in this particular setting, it's going up. And so I wanted to sort of understand the landscape. And so we call it the context that's in almost all of them. So you have to figure out what you're might have to do a little differently. Peru is a low and middle income country. I actually really care about middle income countries. I don't know why. I just feel like that they're stuck the most. The low income countries, they just get a bucket load of resources from the international community. Places like Georgia are talking about phasing out their resources. So they're really in that sort of struggling area. And then the high income setting, even if they're not doing a good job, they should be, And so I feel like, this is the place where it's really hard. And in this country, they've got 120,000 or so people with HIV. Incidence is actually higher than for the whole region. It looks like Eastern Europe and Central Asia, mortality is going up. And in this particular epidemic, HIV is concentrated in MSM and transgender women. It accounts for almost 70% of all the cases. So high levels of stigma and discrimination in a very machismo sort of, setting. They don't have a lot of injection drug use. And so, certainly there's club drugs and all kinds of things among MSM, but it's sort of moving me, in a slightly different area. And one of the things that I liked about this from my perspective is I have a lot of funding from NIDA, the National Institute on Drug Abuse, and I've got some funding from National Institute on Aging. But this was really getting outside of that, and it's another funding agency to sort of diversify your portfolio. And one of the things that they said was, they sort of said, well, we'd like to take care of this all over the country. Peru is diverse from having clinics along the Amazon where they reach people by boat. So, that's part of it. And then there's this big urban area where most of the cases are. 64% of all the people with HIV are in Lima. And I really said, all right, from a feasibility perspective, start somewhere. And so we began to sort of think about where is the money? The famous bank robber, Willie Sutton, it says, where is the money? And, it's in the banks. And that's why you go to the place where there's a lot of it. And Lima is an interesting place because it is this huge urban sprawl. It is spread across 100 kilometers. I mean, there is a lot of space to get through. And most of the HIV clinics are, you know, kind of centered in a certain area. And so what we started to do was we started to really understand the landscape. What does it look like in order to provide care there? And the problem that they had was that, you know, that I should have gotten the cascade. Did I skip over it? Well, here. So one of the things that we did was we looked at the cascade to figure out, you know, where to do things. So they're doing pretty good at testing people. They're almost at their 95 target. So let's not spend any time there. Now, from a prep perspective, you want to test people and then move them down the other cascade, but that's a slightly different question. And so they have a lot of people who are diagnosed. They're actually getting them to the clinic. But boy, look what's happening. They're dropping out of care. And then, of course, once they are in care, you know, they're engaged in care, they do take their medicines and you have almost, you know, high viral suppression. But if you think about your treatment as prevention, which means that if you get someone non-detectable, they are not transmissible. You shut off that forward, you know, sort of transmission. And so what we really said was we want to think about retention and care. And we looked at some of these sites and people were dropping out of care because they were basically sitting on a bus all day long, getting to the clinic. These clinics are 3,500 to 6,000 patients each. They are huge, monstrous things. And we did walkthroughs. We said, what does it look like to go through the process? We couldn't even find the HIV clinic in one of the places because you had to walk through another place. We had to go through a security guard right up front and say, where are you going? We're going to the HIV clinic. You know, so you can imagine these are structured things. And so these were some of the things that we were thinking about, but we wanted to focus on retention and care. And the country already had a problem as it related to the process of decentralization. What these represent is in the circles are these big, huge hospital clinics. And there's a few more than just this. And as it turns out, we got funded to do 4 sites. And when we got started, we said, you know, we can add on one more site and build it into our sort of design. But you've got essentially these big hospitals, and they have a regional network of primary clinics that are assigned to each hospital. Now, one of the problems is the people in the primary care clinics had no idea who those people were in those other settings, and vice versa. In fact, you'll see from some of our preliminary data that there was a real disconnect about even knowing what was going on in the other sorts of settings. But what this does is this sets itself up either for, as Mona would say, a cluster randomized trial, or in our case, we just couldn't do the work with all of these settings at the same time. And so it became infeasible or unfeasible for us to be able to do this as that. So our scenario is what drove the way that we decided on the trial. And once again, it was Denise, and she actually didn't try to talk me out of that particular trial because she said, I don't know how you're going to do all of this in that sort of way based upon the types of activities that we were putting together. So anyway, one of the things that was really clear is that when we did our walkthroughs to try to understand the landscape, it was really complicated for patients. You walk through the security gate. I mean, we were going in to do a walkthrough and we were in a line that was at least from, you know, twice from here to the door. So there's a whole process. You have to find the place, you have to go through. And the way that they did things was cumbersome. So that's what we would call a flow chart. What does it look like for a patient to do that? So we understood that there were many, many complex processes. And the other sorts of things that we had to understand is, were there any potential other things that were getting in the way? Was cost an issue? Well, the transportation to and from there was, you know, one of the big issues, but all the medications and all the laboratory testing, everything else is free. So that's available. They've got this really centralized healthcare system that they're trying to change, and it's concentrated in these clinics. And they had set these targets to get 80% of their patients within 5 years into these things. And of course, we're already at that point. And there's, you know, maybe 10%, 10 to 15% of the patients who are in the primary healthcare centers. And so once again, this evidence-based practice, this recommendation, this guideline approach to decentralization was really not being sort of met. So I think it's important to have a, kind of a problem statement. Decentralized HIV care is an evidence-based strategy more than a practice. It's a practice, and it's recommended by international organizations. What we did when we did our review of the literature is there were all kinds of studies out there that showed that decentralization works. Well, guess what? There was no guidance on how do you do it. All right. And so what we did was we looked at what was there. There was a systematic review, and this is how you do it in low and middle income countries, 56 studies in 26 countries. So we've got a lot of stuff out there, and it gave us some information. But what we knew from almost every study is it seems to increase retention and care, which is targeting the outcome that we wanted. So we have a match between what the problem is, so our problem statement, and what we're going to do about it. So we're going to focus on that. Primary health clinics are typically more agile and accountable to the district where they're doing their work. They must have sufficient, this was important for what we decided to do as our strategy, sufficient technical and clinical skills, all right? They are able to be a little bit more nimble, which means that process improvement is likely to work a little bit better under these circumstances. And all of those positives were countered by the qualitative studies, which showed that the qualitative studies showed that it reduced access to specialists, so that it impeded their ability to get to these kinds of high quality secondary health centers, that there was the perception among patients that they felt like they were getting second-rate care because they weren't getting the big shots. I mean, how many people in certain systems, if they have a sort of a congested nose, they go to the ENT person instead of to their primary care first. And there was also some fairly good data and quantitative data that shows that patients get there, it's easier, and it works well. But not a lot of that on HIV, and you'll be interested in finding some of the early things. What we seem to know is that the concerns by the primary care clinicians was they just didn't feel like they had the confidence to do HIV. They were like, okay, that's what specialists do. We don't do that. So there's a lack of confidence from their perspective that they could manage it. And that they said, we're busy. We don't have time in our slots to deal with these patients that may be impossible to take care of. Not recognizing that our pills are simple. They don't have a lot of side effects. They're really easy to do. So HIV care has transformed. When I went through my training, they didn't have any HIV medicines. But earlier on in my training, the medicines were complex. There were drug interactions. There was everything and the kitchen sink. And, you needed someone with my skill set to do that. But that's just not where we are today. It has really been sort of transformative. And then if you sort of look at the other set of stakeholders, is these people in these secondary centers, they have these longstanding relationships. They don't believe that the doctors out there, oh my God, they're going to kill my patient. I can't send my patients to those people. Or they didn't feel like that there was going to be, the confidence. But the other thing that was interesting was they said, I don't want to lose my relationship with my patient. My relationship is important. And no matter what you recommend, it's important to understand what those perceptions are in terms of selecting the strategies that you're going to do in order to make this sort of work. What we had to figure out is, what are we going to do that's different? What's going to be novel that's going to sort of add to the literature and to leave you with some kind of tool or something that's going to be important? But what was interesting is this process of decentralization had never been studied in an experimental design. People just did it, they reported the outcomes, and it worked. But that's important. That's health services research. It's really informative. There were no implementation studies that were done in urban studies. Almost all of them were done in places where people had to walk a day across the desert in order to get to care and stuff like that. Mostly done in sub-Saharan Africa. And so they moved it out. So there just wasn't that in an urban setting where you've got traffic and all these other sorts of things. But you can imagine it takes as long for people in these urban settings to get to places with the marshukas and stuff like that, to go from place to place in order to get that. And then there were some other things that we were adding to this, because what was so interesting is they've got a secondary hospital. They have no idea who those primary care, they're out there. They're those people, and we will take your folks. And that's all it is that they know. And the people in the primary care clinics, I don't know that doctor over there. So there was no network. So we basically did some redesign of how, well, that's what we had to figure out was we had to do some, redesign. Our goals, I love Mona's way of putting the arc up there with the arrow. You sort of do the sorts of things. One of the things that we realized is that there are no guidelines for how you do this. So we did the Delphi method. I will never do the Delphi method again. I've done it twice and I'm just, it's so hard to do it because one of the things that's, or I would do it maybe perhaps differently. I think I would do it differently. The Delphi method is a very solid sort of strategy, but it drove me crazy getting people to sort of respond to all the various different things. We were chasing people like crazy to get their sort of responses in, what's important to know for a transfer, what needs to be in a flow sheet and all those other sorts of things. What are the criteria? When do you decide to transfer people? And do you maybe early on make sure that patients are stabilized before you send them as a first step? Or do you just take them right from the very beginning and stuff like that? And so there was a paternalism that happened, but it's important to sort of recognize that. And so going through some of that, what's important to recognize as quality health indicators? I think you saw Atiri's presentation that when they get into primary care, you can also take care of a lot of other things. And so recognizing that, but there was no sense from these secondary health and the HIV experts that these were even relevant or important today. So that's one of the problems that I think that we struggle with regard to that. The next step is to really sort of expand upon and prioritize those barriers so that you can have actionable items. And then, of course, remember specific. It's a type 2 hybrid step wedge design. It ended up being with 5 hub and spokes using the REAIM framework. And looking at outcomes, I shortened that because I couldn't get it to fit on the page. And so what we did was we looked at this and thought about what kinds of problems were there in doing the implementation and what do we need to do. And first of all, this relationship building was really important. And so what we did in terms of your strategies is we did organizational redesign. This one was not really hard. Sometimes organizational redesign is really hard to do because nobody wants to make a change. In this case, there was universal sort of interest. So create hubs and spokes, primary care clinics that coordinate and collaborate with those sites. We use a blended strategy. You've heard about Niatex. I'm not going to spend any time doing that. Simon? Okay, we can quit. Huh? Yeah, let's do that. Yeah. It's all good. Listen, if we don't get through, I have to tell you that they did such a good job that I'm going to be repeating some of these very same sorts of things. But it was really, it's about like writing grants. It's repetition and it's sort of reorganizing and repeating it. So you hear it slightly different ways. You're not going to hear anything that's going to knock your socks off in this. If we don't get to it, we don't. But if we take a couple more minutes, we'll do that. Go get your coffee, go get your beverage of choice, go get a snack. Come back and be refreshed. And if you need to take a nap for the last 10 minutes, we can do that. All right, we're good.